that's it for Tiffany's lecture.
Yes?
Do you have any like objectives that you would let out?
Do you think I have them right now? No.
No, not right
No.
now, but just in general.
Let me look. I think a lot of what I've got already in there as objectives will work, but I'll go back and look.
Okay.
Because she really gave you a lot of detail.
Yeah.
She's amazing. I worked with her at OU, and I really, really respect her. Okay. So the good thing about asthma and COPD is that the drugs are pretty much the same. There's a few that we use in COPD, like Dalarest, that we don't use in asthma. And we don't use the muscarinic inhalers as much in asthma as we do in COPD. So that's nice. You've got about the same amount, or two drugs. A category of drugs fits two different diseases. So in that first, this is a nice little drawing. You have to kind of dissect it a little bit, but it kind of points out where all the different drugs, except for the last, the interleukin-5 products. But the mainstream, it shows you that the corticosteroids are going to work on the airway, inside the airway, the lumen of the airway. Their big job is to get the inflammation under control. That's the big push. That's the big goal you have in asthma, is you've got to get the airway inflammation under control. If you do that, their symptoms will go down. If you don't, they will continue to have breakthrough and exacerbations, and it'll pop out in different ways. The bronchodilators work on the smooth muscle. Okay? So when they are stimulated, they tend to cause bronchoconstriction, but when we use the beta agonists, we get bronchodilation. Then the leukotriene modifiers are mostly modifying cytokine release, so mostly from mast cells or some of the other inflammatory cells, but mostly the mast cells. The leukotriene modifiers work there. Cromolyn and nidocromil, the mast cell stabilizers, work on the mast cells. They stabilize, this cross-link those different IgEs that are sitting there and keep the mast cell from degranulating. So they're one of the few that works on both the late phase and the early phase of an allergic reaction. And then Zolar works back here with the IgEs. They bind them up. And then the interleukin-5s even work prior to that. They work on the eosinophils. Okay, so those are the different drugs we have. I think I've mentioned all of those. Okay. So let's start with the bronchodilators. Let's look at those general statements on the bottom of page 2. So at break, y'all can come get the COPD handout. So bronchodilators is like, it's just telling you what they do. So there are three types of different bronchodilators that we have. One are the beta agonists, the other the antimuscarinics, and a third that we don't use very often anymore because it has lots of toxicities. It used to be the #1 drug, but it's moved down with the other drugs coming on the market, is theophylline. So bronchodilators are a mainstay of COPD. They are used primarily in PAL in asthma. They're used mostly as rescue, but we can use them some in maintenance. Inhaled route is always preferred. The side effects with oral bronchodilators is usually much more. The systemic effects usually make the drugs hard to tolerate. So the short-acting are prescribed on an as-needed basis, so they're PRN. They are also your sentinels. What is a sentinel? A guard, yes. So sentinels watch, do they not? They watch for the enemy. So short-acting, especially beta agonists, will tell you if the airways are not very well controlled, because they'll use them a lot. So always when you see people with asthma, you want to ask them, how often are you using your albuterol? Some of you had a patient like that with the SPVL, right? Mm-hmm. Okay. So one of the things, if they're using it a lot, it's telling you that their inflammation is not controlled. So we're always going to use the short-acting as a monitoring or a watch over how well things are going in the airway. Long-acting inhaled bronchodilators are always used for maintenance, never for an acute situation. Okay? They just don't work. And they can be detrimental. Long-acting inhaled bronchodilators reduce exacerbations, decrease hospitalizations, improve symptoms, health status. So those are some of your big outcomes that we're watching for. Tiotropium would be an example of that, or Spiriva. It's one of the oldest ones in that category. Combining, especially in COPD we do this, is we combine bronchodilators from different classes. So you might use a short-acting beta-2 agonist and a short-acting muscarinic together. We even have products, Combivent, that's what that is. Got an anti-muscarinic and albuterol, a beta agonist. Okay. We do that for COPD. We don't do that necessarily for asthma. Okay. So there's a difference in the pathogenesis that's going on and why we use one over the other. Questions about those general statements? Pretty much holds through for both diseases. Stop me if you do not understand or if I'm going too fast. Okay, so bronchodilators are working on smooth muscles. They're working on beta receptors or muscarinic receptors. So in usually established asthma, you've got a hypertrophy of those smooth muscles around the lumen of that airway. Right here. So the adrenergic nervous system really maintains the airway tone. It regulates how small or how big it is. Okay. So in asthma, when you have lots of irritation going on, the body's reaction is to clamp down, to try to localize. So you get constriction in those areas, and that is what that's what brings on those symptoms. So what would be the symptoms? What would your patient complain about if they have bronchoconstriction? Shortness of breath. What else? Wheezing. What else? Could be cough, chest tightness, dyspnea. How do you tell that in a child? Child can tell you I'm short of breath? No. Now those retractions would be in a very acute, worse. But how would you tell otherwise? Okay, too acute.
Maybe they're not playing as much?
They're not playing as much. So if they can't get air, what you ask for with kids is, can you go out and play with all your kids at recess? Do you play with your friends at recess? What do you do? Or you can ask the teacher, or get information through the teacher. Do they sit during recess? Do they run with their friends? Or do they tire out and come sit down? What do they do at recess? Can they do daily activity? Can they climb the stairs if they have to? The chores that you give them, can they carry them out? If you're at home and you send the kids out, can they play with their siblings or their friends as long as they need to? Does cold air seem to make them cough more, make them wake up at night and complain more? So those are the things with children that will help you. Missed school. School is another one. How much schooling are you missing? The average kid with asthma misses about 13 days a year. 13 days, it's almost 3 weeks. I've seen kids held back because their asthma is so unregulated that they miss too much school. So that's one of the Now, you also have to look for malingerings because they figure it out. But most of the time, the mom will know, the parents will know. Okay. All right, so let's look at page 4. So remember those big receptors we talked about that went across the whole cell membrane? Well, here's one of them, linked to these beta and gamma and alpha subsets. So when a beta agonist sits on that receptor, it acts like the endogenous products. Okay, so those are the catecholamines. So what eventually happens is that you have adenyl cyclase converting ATP into cyclic AMP, and you get an impairment of intracellular calcium movement. And that calcium is important for the ability of muscles to contract. So if you decrease the amount of calcium available, and you inactivate myosin, remember myosin is one of those chains in a muscle that helps with contraction. Remember they slide over each other to shorten a muscle? So those are impaired, and so the muscle relaxes. And it's pretty much immediate. They get immediate care. You don't have to teach patients much about what a beta agonist does because they get relief so fast. So they know. Short of breath, dyspneic, coughing a lot, I can take my albuterol and that will go away. So under that kinetics, rapid onset of action. Very fast, 5 minutes or less. Duration of effect is short. 4 to 6 is what you usually see. And the beta-2 selectivity is relative. Albuterol is pretty beta-2 selective. The older agents like isoproterenol, beta-1, beta-2. So what do you think happens? What would be the difference between giving them a non-selective versus a selective? Heart rate, so it's side effects mostly. So the more beta-1 you have, the more side effects they get, especially cardiac, so tachycardia. For kids, it's like peeling them off the wall. It's just very hyper-excitable. Can decrease potassium levels as well, but big thing's going to be their palpitations or heart. So what are they indicated for? They're indicated for quick, they're the drug of choice for acute bronchospasm. That's asthma and COPD, both. So they are rescue drugs. So whenever you sit down, and I know he had this in the slide set, whenever you sit down with patients, you always ask them, which one's your rescue inhaler? You use those terms with them so they know. Rescue, and then we use different words for their maintenance. Controllers. I use controller. Under that last bullet, they do not treat the disease. They only go after symptoms. So I haven't seen it so much on the news, but I'd say 15 to 20 years ago, wasn't uncommon to have on the news where someone died because they overused their inhaler, they couldn't get to the emergency room. Had this happen in pharmacy school. We had a couple of women die because they had their inhaler, they underestimated how bad they were, they got in their cars, and they never made it to the hospital. They were either, one was on a weekend, one was on a Thanksgiving weekend. So it's really important that beta agonist action, how they're using it is really important to know because it tells you how well it's controlled. With the inhaled steroids, a lot of them don't use it because they can't tell it makes any difference at all. So but they know the albuterol makes a difference. Okay? So it's always that education is really important for what are foundational, because the steroids in asthma are foundational for most of your patients. You've got to have it on there. Anybody beyond intermittent should have an inhaled corticosteroid on board. The other with these is technique is really important. I know she talked a lot about the devices, and we're going to go a little bit into detail to remind you about those as well. So the ability to use those products is important. So if patients are using them a lot, another thing to think about is, are you using it right? So in my clinic, we kept dummy inhalers. If a patient had their inhaler, we'd say, okay, you got your inhaler with you? It was unusual that they didn't. It's like, okay, show me how you use it. So it gave me the opportunity to look at, well, to ask questions. How do you know when it's empty? When was the last time you refilled it? I can also dig the gunk, because they don't like to put the cap on it, because they like to keep it off. So I've dug pennies out of their stuff. It's like, okay, you don't want to inhale this, so please put your cap back on. And just dirty, oh, gosh. You know, it drops down in the floorboard of the car, they just pick it up, throw it back in their purse or backpack. Okay. Dose is usually, I would say for people who are well maintained, it's usually 2 puffs at one time, okay? If you're pre-treating before activity, it's usually going to be 2 puffs. That 4 puffs comes more when you have got an acute exacerbation. So 2 puffs every 4 to 6 hours would be a correct dose. Delivery mechanism for the beta-2 agonists, you've got meter dose inhalers. Those have been around a long time. You've got the dry powdered inhalers. And you've also got the mist. I didn't put the soft mist in there, and also the solution for nebulization. So we can get that drug into a person. Adverse effects, so sinus tachycardia. Kids, it's not so much a problem. As you get into older adults, then you can see arrhythmias pop up. They can also get very tremulous. And it's just a resting tremor. And they'll be anxious, and they will be, it's like they're hopped up. They're just more vigilant, can't sleep, insomnia would be another one. That's where I look and see how are you using it. Others, headache, dizziness, cough. Cough would go to their technique. If it's hitting the back of the throat, it'll irritate it, especially if they're already have a pretty irritated airway. So some of that goes to how they're using it. So often if the cough is the main problem, I'll put them on a spacer. I like spacers. I usually recommend them to most folks. Or if they're using a closed mouth, I'll try to get them to do an open mouth if they don't want to use a spacer. Can decrease serum potassium. This would be with a lot of use. Usually you're once or twice a week, you're not going to see that. Kids, not so much a problem. Especially if you've got an older adult and they're using it with diuretics, but there's no potassium supplement. So what do we expect? We expect their FEV1 to go up. This should be easy to remember, because on spirometry, what do? We have them do it at baseline, and then what do? We give them a bronchodilator, and then we take another to see how they respond. Okay, so FEV will go up. Let's see.
Are these contraindicated for anybody with heart issues?
No, not really.
Are there really any kind of?
No, because if they're using it, if they are well controlled, they will not have these. These tend to be from overuse, poor technique is what you'll see these a lot. So in the short-acting, there's 2 main ones, albuterol and levobuterol. I like albuterol. It's expensive enough. Zofinex, I don't feel like there's that much benefit over it to justify it, but it's another one that's out there. The older ones are still around. I would say there's albuterol's the best in that group. Lots of different brand names. Proventil is a very common one, but it comes generic. Hold on, let me finish this stop picture. I do want you to know that dose. It's just so common that you're going to use it a lot. So 2 puffs every 4 to 6 hours. PRN. Yes.
Our speaker on Friday said that the leave albuterol had fewer of the shaky side effects. Would you agree with that? Because he said that was his preferred. I don't know if this is preferred, but he liked it a lot because of that.
Okay, so that's his experience. I just would not do it. It's more expensive, And I think if they're not using it a lot, which is your goal, they are not gonna have those side effects as much. That's my opinion.
Okay,
My opinion.
thank you.
You have to remember, once you get out there, you'll start experiencing it. When drugs go generic, nobody cares. They will never send you a rep to promote a generic drug, never. But they will send them to promote the brand names. So Zopanex got their message out there. I'm not saying it's a bad drug, I'm just saying I just can't justify the cost over. My opinion. So weigh them all, take them all in, and your patients would probably complain. I think the cheapest I have seen albuterol is like $50 an inhaler. Most of these inhalers go from $250 to $400 an inhaler. They're just ridiculous. So Advair now is like $275 without insurance. You paid $65 with insurance?
Sometimes you get coupons on websites too.
But if it's preferred by your insurance, so if it's not preferred, they'll make you pay the retail cost.
I think I get Ventolin, which is for the albuterol, and it's $5, maybe 5 or 10.
Then you have good insurance, because
I do.
most people's insurance is not that
Through
good.
the city.
They're paying, you know, $50 for a inhaler.
Okay, so the long-acting beta-2 agonist. Mechanism of action is the same as the short-acting, it's just they have manipulated the drug in order to make it sit on that beta receptor longer. It's a controller, never a rescue. You have to make sure patients understand that they do not want to grab that if they're having an acute attack. Really important.
Isn't onset like 30 minutes, I think? 45?
It's more that if they are getting in trouble and they start to use it a lot until they can get to medical help, it just won't do anything. And for a long time it carried a risk, and I think I took it off of your handout, but it had a black box warning until last year, is that there's an increased risk of death due to the overuse of long-acting beta-2 agonists. Indications, so persistent symptoms. So you'll see it start to pop up when you get into the mild or to the persistent category, the persistent steps. Only use it in conjunction with an inhaled corticosteroid. Never use it by itself. Now this is for asthma. For COPD, we use long-acting beta bronchodilators with the short-acting, very different. So this is a diversion. It's indicated for step 3, which is it's either the more severe, I can't remember, is that step in mild or moderate?
It's moderate.
Moderate, okay, it's the first 3 and 4 are moderate. In COPD, LAD can be used with short-actings appropriate for all stages. So pretty much the next thing we add, if they're not getting good relief from a short-acting in COPD, is we add a long-acting. It can be a muscarinic, it can be a beta agonist. Contraindications, this is really important. Avoid using these products with strong 3A4 inhibitors. So clarithromycin, ketoconazole you're not going to see very much anymore. Ritonavir would be with AIDS. The one out of there you're going to see the most would be imapronate. So the clarithromycin. Onset of effect is longer, so 1 to 2 hours. But they last a long time. They're usually used twice a day. They last about 12 hours, right?
Are the contraindications just for oral, or does that apply to, like, say, topical ketos as well?
It's just for these, I can't hear everything you're saying, so
oral, is it only oral with those particular medications? Like, I know because the keto has like a topical. Does it have the same effect on that? Okay.
I don't think the topical, I'd have to look. I'd have to look it up. I don't know how much systemic absorption you get out of the topical. On the long-acting, the one I would like you to know is salmeterol, Ceravent Discus. It's one of the older ones. The rest of them are similar. They come with different types of inhalers. You'll see that one's a dry powder inhaler. The others are, you've got some Respomats, you have some soft mist in there that are, those are nice. And so the newer ones, like the Orcapta and the Respomat, are once a day. Questions about those? Okay, let's look at the anticholinergic bronchodilators. Here we're going to see these used mostly in COPD. There is some use of these in more acute situations, like in the hospital. If they're not responding to an inhaled beta agonist, we may add an antimuscarinic like ipratropium to that inhaled. But for the most part, this is going to be COPD. So these block the effects of M2s and M3 muscarinic receptors. The parasympathetic nervous system plays a bigger role in maintaining airway tone in COPDers than we see in asthmatics. In asthmatics, it's more the adrenergic system, not the muscarinic. So the short-acting can be used for bronchoconstriction acute. The problem with them is that they're delayed. So that's why we don't go to them in asthma, because their onset is about 30 to 60 minutes. So we don't use ipratropium usually by itself as a short-acting bronchodilator in asthma. These are used on an as-needed basis, so if you're going to use it for the most part, as needed. In COPD, we tend to move more towards scheduling, even short-acting for patients, but in asthma, we do not. Okay, so there's a difference. Have I got that? Okay. These are fairly well tolerated. They don't get absorbed. They've got a big ammonia ion connected to it, and it makes it very hard to get absorbed. So that's good. You don't get a lot of side effects. The biggest problem is people, and this is pretty common, is people squirting into their eye. Then they get side effects. Especially those with acute angle glaucoma can precipitate a crisis in their eyeball. So making sure, that's why I don't tend to use the open mouth technique very often because of that, and also I just like spacers better. So anyway, less common concern is worsening of prostatic symptoms. It's not very common, but it's a potential. Expected clinical effect, their exacerbations are going to go down. Hospitalizations will go down. So we know that in COPD, they do pretty well, especially the mild folks. So they can be used together. You can use a beta-2 with an antimuscarinic. Monitoring parameters are going to be pretty much the same as we saw with the short-acting, is that are they getting relief? How often are they using it? The ones I would like you to know are listed down there. Ipratropium is Atrovent. Two to 3 puffs 4 times a day. Tiotropium is the longer acting one, Spiriva. It's a dry powdered inhaler. 2 inhalations, it is once a day. And then there's the combination albuterol, ipratropium, very commonly used in mild COPD. Either dose inhaler or by nebulization. You'll see down at the bottom there are combination products with the long-acting anticholinergics and beta-2 adrenergic agonists. You'll see this a lot for COPD products. There's lots of combos available in meter-dose inhalers, dry-powered inhalers, and the soft mist sprays. Oh, there it is. So phosphodiesterase 4 inhibitor for treatment of COPD. This is only used in COPD. It works by a different mechanism. It works on the breakdown of cyclic AMP. It is not considered a bronchodilator. Its actions are indirect. We use this in COPD patients who have frequent exacerbations, so it has been shown to decrease the number of exacerbations. That's really important. It's important concept in COPD and in asthma. People are most likely to die during an exacerbation, so we want to decrease those. It's one of our monitoring parameters. It's one of our outcomes is decrease in exacerbation. So that's the big indication for a rhamnolast. So contraindications, liver impairment. Adverse effects, a little bit more common, but this one's given orally. So appetite, nausea, abdominal pain, diarrhea, sleep disturbances, headaches. Weight loss can occur. So how is that a problem in COPDers? What'd you learn? Most of them tend to be skinny, and why is that? They use a lot of energy to breathe. So it's often helpful to send them to have a dietitian involved to look at how can you get high calorie density into them and keep their weight up so they don't get so debilitated. Don't use with theophylline. We don't use theophylline very often at all. They have a similar mechanism of action, so we won't double up on that. Expected effect, reduced exacerbations. And insurance will be on you because it's an expensive drug, so that's one of the things we want to see. But an exacerbation is expensive, if you have to admit that. So it's once a day PO. There's a summary. I think I'll come back to that because it's got the use of corticosteroids in it, so we'll come back to that. Okay, any questions? Okay, let's look at the devices. I know y'all spent a lot of time on these. So the meter dose inhalers, what was your takeaway? What'd you learn?
I'm using it wrong.
I've been using it wrong. Number one reason here for people for it not to work is technique. The big problem with the MDIs is they are heavily dependent on user technique. That's why I like to use spacers. I almost always go to a spacer because I can get around technique. A person with really good technique and a person with an MDI and a spacer, same effect. I just find it's hard to get people to keep a good technique. Technique always goes south. You know the whole universe. In physics, what did you learn? Entropy. Everything moves to the least energy. And it's with skills the same way. I told you about my driver's license in Texas? No. Oh, I must have told the other class at the end of the year. Okay, so when I grew up in Missouri, went to school in Missouri, but when I went to graduate school in Texas, I just didn't pay attention and my license expired. So when I figured that out, it was like 3 months and I had to go. When I went to the, whatever it is down there that you go to get your license. Yeah, DMV. So they said, well, you'll have to take the driving test and the test and the written test both. So I'm like, okay, no big deal. So I just took the test cold. But when we went out driving, okay, so I was held 24, 25. So my technique was so sloppy, about halfway through you go, stop. You cannot pass this test. Like when you turn left and you're supposed to turn clean into the next lane, well, of course, I just cut the other lane off. And I rolled through stop signs. I mean, I was terrible. Even though everybody in Texas rolls through stop signs. Yes, they do.
No stop, no stop.
Yeah, no stop is true. I'll tell you some horror stories in Austin driving without stopping at a stop sign. So that's why, technique always goes downhill. People always get sloppy. So you've got to check technique. When I see patients that are on an inhaler, every time I make them get it out, let's see, show me how you're using it. So that's the big problem with MDIs. The other thing is that you have to have, for little kids, you have to have the ability for your brain to coordinate with your mouth, your breathing to coordinate with your muscle. So it takes about 4 or 5 before kids get to that point. So you can use an inhaler in very young babies, infants, and toddlers by using a spacer device. But they have to get to about 5 before they've got enough ability to coordinate those 3 things to use an inhaler correctly without a spacer. Let's see, anything else there? The other is that you have to have a pretty good updraft. You've got to be able to carry enough air and airflow to get medicine down into the airways. And that when that medicine comes out of the canister, it's in all different sizes. So the big stuff will fall out. If they use a spacer, it falls out the spacer. If they use a closed mouth or an open mouth technique, the 2 fingers, it falls out. But if it's in the closed mouth technique, they'll get a lot of it deposited in their mouth and the back of their throat. So which technique to use depends on patient's ability. It's that slow, deep breaths too, and the ability to hold your breath. Usually we like to hold them to the count of 5. They do 10, that would be great before they exhale it out. You can tell if patients do, actuate, take it in, and as soon as they do that, they breathe out, you'll just see a little cloud come out with their medicine. That's the medicine going away. Okay? So that's why holding that breath is important. So that makes these devices harder to use. So that's why they came up with the dry powdered inhalers. So here's those different, here's this lady showing a 2 mouth, an open mouth. This one's a closed mouth, and that's with the spacers. Did either one of them have a preference?
Yes.
See, anybody, huh?
She liked
Open mouth was preferred over closed.
She did? She said why?
Spacer was preferred over. You inhale more rather than going into your mouth with the closed.
She still prefers the spacer. She's just like, if you can't use a spacer, then use open mouth.
That I agree with. Closed mouth to me is the very best.
Yeah.
But you know what? I do teach patients all 3 because they often won't carry their spacer with them. So some of them are huge. The big one is about 750 mils. It's big. There are some that are collapsible and easier to carry. So that becomes a problem in people actually carrying their spacer with them. When I was a resident, there were no spacers. We used the end of toilet paper roll, or the cardboard in toilet paper. That was, I mean, we figured it out pretty early, is that if you could do that, you could get more drug down and get over the technique problems. So on peds, that's what we did. We used that little short cardboard roll. Okay, dry powdered inhalers. So dry powdered inhalers. So these came about, this is just one example, is to get over the technique problem. The other is that, at least for COPDers, you don't have to have that big updraft. So low flow of air from the mouth down into the lungs is easier. And so you can get the drug down there. So that they came about. There's 2 different types. Did you learn about them? So the first one is kind of self-contained. So that's Advair. It's a combination of an inhaled corticosteroid and salmeterol. It has all the doses are contained, so it has 200 doses in it. But the other type is a single dose. Did y'all talk about these? So this one is Spiriva. It's a handheld. This is what it looks like when it's closed up. This is, can you see my mouse? You can't when I'm in this that. Okay. Here it is closed up. Here it is when you open it. So you can see the mouthpiece at the top. When you open it again, there you see a little hole, and that's where the capsule fits down. It has a little needle in it, and when you close it up and press that blue thing at the button at the side, it pierces it, and then as you breathe in, you take that powder with you. Okay. Biggest problem is getting them don't swallow the capsule. Okay, and there it shows you. So low flow, most of them have, and almost all the inhalers now have a counter on them. It'll tell you how many are left. Some of them do it per count, some of them do it groups of 10. So that's good. So patients don't have to guess so much if their inhalers are empty. It is hard to tell a half empty from a empty canister. The dry powdered inhalers are listed down there. You'll see that they're very popular because look at all the types of devices there are. So Ellipta, Discus, Flexhaler, Handahaler, Neohaler, Pressair, and Twisthaler, those are all the patented types of dry powder devices. So you'll see it hooked on to a name like Brio Elliptica. Okay, Ellipta. So that tells you the brand name, it tells you the type of dry powder inhaler device. Another more recent device are called the soft mist inhalers. These are nice and for a number of reasons. One is that it's a mist, so the dry powder sometimes will make people cough. Just the presence of that powder, some don't like it. Some of them contain lactose, so that causes some patients problems. I think Advair had lactose. I don't know if they've taken it out. It was a problem for a while. The mist hangs around longer. It's a little bit heavier, and it holds together easier, so the patient tends to get more drug out of that delivery than in the other two. It is pellet free, so it has an advantage over the MDIs, but it does contain benzalkonium chloride. Do you remember anything about that? I talked about it in dry eye products.
Yeah, it was a preservative.
It's a preservative.
Really irritating.
It's irritating. Well, with the eye, it can damage the cornea over time. It doesn't really damage anything here, but some people are allergic. Some people can't tolerate it. So that is present. About 75% of the aerosolized particles that are produced are the size that can be inhaled. That is a unique difference compared to the other two. Lower velocity decreases the deposition of the drug in the mouth and in the throat. And it reduces the problem of coordination of actuation inhalation. They're a little bit more complicated to use, but once you teach a patient how to use it, they can certainly handle it. It does have an indicator on the back that tells them when it's empty. That's a great advantage. So I like these a lot. I don't see as many patients on them. Kristen, when you were in the pharmacy, did you see these prescribed much? It may be, I bet you the cost is high, but I like them.
Yeah, there was like that select few that like stuck with it every month, but they weren't.
Wasn't a big use.
No.
There's more and more Respimats coming out. There, for a while, Combivent was it, so it had only been COPD years, but now there's more of the different products that are going that way. Okay. And you talked about nebulizers. So nebulizers are great, but they should have limited use. Often there is a go-to. There's a great discouragement now. They make you fill out a lot more paperwork if you want to do a nebulizer. But nebulizers really tie you down. If you're going to deliver a drug via nebulization, it takes about 20 minutes, 15 to 20 minutes. So for a kid, that is an interminable time for them to sit with a mask on their face. But for COPDers that have really difficult time breathing, this is a good option. Or if you've got a kid that has a lot frequent, maybe you've got, I've seen families with 3 kids that all have asthma. So it might be something to keep in the home in that case. But for the most part, you should not be using a lot of nebulization unless you're dealing with COPDers. It's also not portable. You can't take it with you, so you still have to teach them how to use and carry an inhaler. So that can be a problem in expense. They are also, while they are very convenient, they are high maintenance. You have to clean them all the time. Tubing has to be replaced, masks have to be cleaned each time. They can get pretty, they can just get grunge. So they can come with a mask, they can come with a mouthpiece. I know she showed you some pictures of kiddos, so you can see this little girl with what it looks like. They do come individualized, so that's nice in terms of measuring. There is no measuring. You're just going to dump it into the medicine well. This twists off there at the top, and the medicine goes down in there. Air or oxygen comes up through. You can't do oxygen through these, so that's nice. And it bubbles it up, aerosolizes it. The doses are different because you lose a lot of the dose when you do this. A lot of it just goes out into space and doesn't get captured. So the doses will be different with a nebulizer and an MDI. Okay, so have you heard anything that is different from what you heard on Friday? Okay, let's take a break and we'll come back and pick up with y'all. Don't forget to pick up the handouts and see what you need.
I remember.
Wow. It's just